Juliana is going to present our experience.
Thank you,
So
Doctora.
thank you, Juliana.
Good morning. I'm Juliana Guerrero, and I'm going to talk about intraoperative sonohysterography during hysteroscopic surgery. And I would like to point out that I don't have any disclosure to make. First of all, I want to highlight the importance of seeing. One of the most important senses is sight, and when we talk about surgery, it's essential. In gynecological surgery, when we want to evaluate or treat the uterus, we usually do a laparoscopy for the outside and a hysteroscopy for the uterine cavity. In some cases, we use both of them at the same time, well, at the past. And obviously, when we do a hysteroscopy, we don't see the uterus on the outside. We just have an internal view, not an external one. So our objective today is to demonstrate the importance of seeing the entire uterus while performing a hysteroscopy. We will try to answer these two simple questions. Firstly, should we always perform hysteroscopy under ultrasound guidance? And secondly, what advantages does ultrasound guidance have during hysteroscopy? Well, to start, we believe normal uterine anatomy and a normal endometrium are prerequisites for a normal embryo implantation. And that's why, for us, an evaluation of the uterine cavity is a crucial step for the diagnosis of infertility. And we all know now that 3D sonohysterography is an excellent non-invasive diagnostic procedure because it facilitates the delineation of the uterus in the famous coronal plane. So as we have seen in Dr. Garcia's talk, sonohysterography allows us to perform 3D imaging and enables the evaluation, again, the coronal plane, allowing accurate diagnosis. And obviously, when we have a pathology, we usually do a hysteroscopic correction, as in this case, where we can see several endometrial polyps and the subsequent hysteroscopic correction. But like all surgeries, hysteroscopy can have complications. One of the most common complications of operative hysteroscopies is the uterine perforation in approximately 2% of the cases. This uterine perforation is more common during adhesiolysis, submucous fibroid resection, uterine malformations, and of course, when we have hysteroscopies with difficult entrances. Here we can see a fundal perforation caused by cold scissors. So I'm going to show you how we can prevent this complication using ultrasound guidance and intraoperative sonohysterography. So, medical literature has reported that real-time transabdominal ultrasound guidance during difficult hysteroscopies reduces uterine perforation, as you can see here. And there's a good published made by Dr. Stedmauer and her team that they published on 2017. And this article, which you may find of interest, is a very good idea to read it. Even so, there have only been a limited number of case series in medical literature. And of course, the role of 3D ultrasound during hysteroscopy has not been adequately evaluated. So that's why we want to demonstrate the utility of do sonohysterography and ultrasound guidance during hysteroscopies. So we first described the technique of 3D sonohysterography during a hysteroscopy in a prospective study carried out between October 2009 and April 2010, and we presented in the ASRM. And to continue with this work, we did a retrospective analysis of 1,104 cases of operative hysteroscopies with ultrasound guidance, and we presented this study at the ESRE meeting in Vienna in 2019. A total of 2,151 hysteroscopies were reviewed. 1,047 were for polyps, and they were not included because usually polyps don't need ultrasound guidance. And 1,104 were done with ultrasound guidance, of which there were 608 uterine malformations made by 95 complete septa. You can see here what Dr. Rule's talking about. 168 partial septa, 269 arcuate uteri, and 76 T-shaped uteri. 363 were severe intrauterine adhesions, and finally 133 myomectomy. But let me explain you how we do it from the start. All our surgeries are performed under ultrasound guidance using these Voluson devices and these probes, transabdominal and transvaginal. And here we can see an example. Oh, sorry. This is the example. We are doing 3D, no, right now we are doing real-time transabdominal ultrasound. That's why we can see the scissors. And now we are taking the 3D volume. And that's how we progress, we monitor the progress of the surgery. And as you can see, we make the 3D reconstruction of the uterus and pay special attention here to the coronal plane because it allows us to obtain a precise delineation of the uterine anatomy and the uterine cavity. So we use 3.8 or 5 millimeter hysteroscopes and use different surgical instruments depending on the pathology, such as cold scissors or forceps or bipolar electrode. In some fibroids, we use resectoscopes, and patients are operated with a half-full bladder because in most of the cases, we use transabdominal ultrasound to monitor the progress of the surgery. However, we have to use transvaginal ultrasound in some difficult cases as obese patients or overweight patients, and also in some retrouterine cases. Okay, and finally, we left a Foley catheter inside the uterus for 7 days. Here you can see the balloon of the Foley catheter, and administered estrogen therapy to avoid the formation of new adhesions. And what we achieve in all our patients is to combine the 3D sonohysterography with the hysteroscopy to monitor the surgery, know when we are close to the fundus, very important, and know when the surgery is complete. This is very important too. And here you can see images before and after a correction of a residual partial septate uterus. Let's see some other examples. This is a case of a partial septate uterus. These images show the progress of this surgery, and in this video, we can see the 3D sonohysterography actually at the end of the surgery, in which the complete resection of the septa and the internal morphology of the uterus can be seen. This is the coronal plane, and this image is the same as this image. And here we can see a submucous fibroid resection. This is the fibroid. This is the hysteroscopy. And we can see the exact position of the myoma facilitating its resection. And we can evaluate precisely the degree of infiltration of the myometrium by the myoma. It allows us to indicate to the surgeon how much more resection is necessary or not. This is another example. This is a complete septa case. As you can see, there are two endometrial cavities completely separated, and the 3D sonohysterography let us know that the septum extends to the cervix in a complete septate uterus, and also show the progress of the surgery. Of course, it is important to remember that for septa cases, we have to know when the surgery has ended because maybe we can do it in a complete way. So the coronaplay allows us to saw it. And here you can see an example of a severe intrauterine adhesions. This is a case of a young patient with an Asherman syndrome postpartum for a retained placenta. And as you can see, there's a cavity completely obliterated. And as you know, in adhesiolysis, we try to restore the size and the shape of the uterus. So in this video, what you can see is that there is a part here. It's a part of the cavity which is separated from the rest. We are making lysis of adhesions with scissors, and thanks to the ultrasound guidance, we could find this, the trilaminar endometrium, and repair the cavity. After this surgery, the patient got pregnant spontaneously. So thanks to all these images, we always see the serosa, and of course, it decreases the risk of uterine perforation. And also, when we have difficult entrances, we always use transabdominal ultrasound. I have to say that there have no been cases of uterine perforation in more than 18 years. So it's a very good technique. And maybe you are asking yourself what the limitations of this technique are. Well, we have limitations. You need high resolution 3D ultrasound devices. You need expert ultrasonographers. And also you need two medical specialists, two gynecologists or one gynecologist and one radiologist, and the anesthesiologist too. So, however, we believe it is cost effective because we prevent complication. And it's actually cheaper if you keep in mind the possibility of the complication that can be avoided. And talking about limitations, we have detected poor quality of images in obese patients, overweight patients, in some retrouterine cases, as I said before, but this limitation is partially overcome by the use of transvaginal ultrasound. While the surgeon, this is the surgeon, is still holding the hysteroscope, there's a third hand that is moving the transvaginal probe, and also in some cases we could use scissors or forceps at the same time. So now we can answer our questions. Should we always perform hysteroscopy under ultrasound guidance? Well, we should use sonohysterography to monitor difficult hysteroscopies such as uterine malformation. Remember the possibility of an incomplete resection, severe intrauterine adhesions. Remember the possibility of uterine perforation, and submucous fibroid resection. Remember the possibility of perforation and also an incomplete surgery. So it's very important. And that's our second question. What advantages does ultrasound guidance have during hysteroscopy? It's so easy. We have less complications thanks to the sonohysterography and ultrasound guidance, and we always know when the surgery is complete. So finally, remember what I said at the beginning, seeing is one of the most important senses, but the truth is that what is essential is invisible to the eye. Thank you so much for your attention, and I'm happy to answer you.
Thank you very much, Juliana.